It will be in the archives of the library that I couldn't get my camera to go up. Let me go just one more thing. Okay, people at home, can you see this? Can we get this to advance? I want it to advance. Let me see down here. Oh, maybe I'll do it. Well. See, I can't get the stupid thing to advance. I am mousing it to death. All right, then let's do this. Pardon me? Oh, that sucks.
I know.
Okay, do people see this? Except here you don't see this, do you? Oh my gosh, this happens every single time, and I thought I knew how to make this work.
Why don't you switch into the new display thing? Not the blue button, but the other one?
Oh, the Teams?
Yeah.
Is because I was afraid this was the last 3 lectures and that, heaven forbid, we wouldn't get it to work. Kim, I hate to ask you, would you go get Chantel? All right, so back to the test for just a minute. So the question that was thrown out was number 44. It was on hyperkalemia and what would the interventions be for somebody that has hyperkalemia. So that was thrown out. It's stated less than 25%. It was a select all that apply question. Okay, so those should be up and going for anybody that made under 80%, or if you just want to come in, you can schedule time with me or with Chantel, and we can go over the test and talk strategy. We only have 3 more tests to take. We're getting down to it. So if you have any concerns at all, please feel free to do that. We can always conference. It doesn't require you coming into class or coming into school for that conference. All right, so let's also get some housekeeping out of the way. And that is tomorrow morning. I'm going to remind you all that we have a quiz at 8 a.m. And that'll go until 8:15. It's over the musculoskeletal terminology. Also, there will be a learning activity for class tomorrow that will be due by 11:59. I can't get it to advance. Accounts. Oh, now it's moving. No, but wait, how do you get it to go back? Back.
Yeah, left arrow.
Alt, left arrow.
Oh.
It says Alt.
Oh, usually it's just your left arrow.
Let's try Alt, left arrow. It's just the most annoying thing.
this isn't even working on it. That's so weird.
I know. And then this over here. So I pulled up one that is full screen, but it doesn't. People at home can see it, but they don't see it here.
Okay. Let's see. So you uploaded that there.
On conference, and then I have one over here that I can pull up, but the people in the class won't see it compared to the people at home.
Okay, so if you pull it up and put it in presentation mode and share your screen.
So, okay,
So
so
you're sharing your screen.
So let me stop sharing my screen for just
Okay.
a minute. Maybe put this up and pull this down and they can just look at it from there. They've got their own screens at home.
Yeah, but it's not advancing for you.
But see, I don't have this portion down here. When I make it full, well, now I do. Now I do. Okay. Let's see. Why isn't this coming up? Oh, I got this up. Never mind. So escape, go back and get rid of this. This was up there.
Right here, maybe. On the PowerPoint. Can you close that up? And it shuts it off. What the heck? Okay.
Yeah.
Is it? It's saying it has no video input.
I can load it up again if you need to.
I am not detecting video. Okay, I'm gonna unplug real quick. There is detected. Okay. And then if you open, let's see, if you share your screen.
Sure this.
Yeah, your entire screen.
Still don't.
Okay,
I have
and
it on
now pull
sync.
up your PowerPoint. Where's your PowerPoint?
Well, it's disappeared. Why? Because it just does.
I know. I know. Okay, now it says you're sharing your screen, but you're... Okay, do your Control F8. So Control F8. And then it's on duplicate. There we go.
Okay,
So then you can just click off the sidebar there. Okay, now see if it'll put it in presentation mode.
I know, but the thing about it is that it doesn't progress.
So now see if it will.
Okay, now it will. Okay, we're good. All right.
Oh my heck.
She saved it once again.
We only have 5 lectures left, Vic.
I know. Well, there was 15 minutes.
I know.
All right, here's Mark coming in. All right, let me finish this.
For Mark's tricks that I tried.
Okay, let me finish this list of housekeeping. So there's a quiz tomorrow at 8 a.m. There is a learning activity tomorrow that is due at 11:59. And we also have a student presentation tomorrow. So I will teach today until 1:20. And then tomorrow I will teach for an hour and a half until 9:30. And then Chantel will take the rest of the time. Again, if you decide to come in, you want to go over your tests or that type of thing, it can be done via a conference or at a scheduled time. Those conferences have to be scheduled, or it can be done in person. So, just because we took 15 minutes right now to do this PowerPoint, I thought maybe I'd go over the quiz tomorrow, just briefly, because you guys are so patient. So I'm just going to read the questions and answers. I'm just saying. because you need something because of the tremendous patience you've had with IT. So tomorrow, question number 1, what is assessed as part of sensory function in the neurovascular check? Capillary refill, edema, numbness and tingling, flexion and extension of distal extremity. What is assessed as part of the motor function of the neurovascular check? Oh, sorry. Do you want me to give you the answer to number 1? Forgot. Okay, it's the numbness and tingling. Look at that adjective up there in the question, the sensory function in the neurovascular check. This next question has to do with the motor function. So the options are capillary refill, edema, numbness and tingling, flexion and extension of distal extremity. So it would be D, a flexion extension of distal extremity. What 5 things are assessed as part of circulation in the neurovascular check? Pulse, cap refill, edema, no, this is temperature, color, and edema. Yes. The patient just returned from a left total hip replacement surgery. The physician has ordered neurovascular checks every 4 hours. Where will the neurovascular check be performed? Remember, this was a left total hip. So all 4 extremities, bilateral lower extremity, left hip area, left lower extremity. Left lower extremity. Okay, the patient's upper extremity strength is assessed as normal when the patient's hand grip reveals which of the following? Both hands are equal, the dominant hand is stronger, the non-dominant hand is stronger, neither hand is stronger because the individual will vary in strength. Both hands are equal. Number A. The patient is being assessed for range of joint movement. You ask the patient to bend the arm. This evaluates which of the following movements: flexion, extension, abduction, adduction. It's flexion. Which of the following range of motion movements can be performed on the hip? Select all that apply. Circumduction, abduction, adduction, flexion, extension, rotation, supination, and pronation. See everything except the supination and pronation. Which of the following range of motion movements can be performed on the neck? Circumduction, abduction, adduction, flexion, extension, rotation, supination, pronation. Everything except supination and pronation. A patient is on hip precautions following a total hip replacement surgery. Which of the following hip positions are contraindicated? Adduction? Yes. Abduction? No. Flexion past 90 degrees? Yes. External rotation? Yes. Internal rotation? Yes. The patient has a shuffling gait with increased step speed. He appears to hesitate both in initiating and in terminating ambulation. The patient is most likely experiencing which pathology? That would be Parkinson's disease. And there we have it, people. There we have it. So today, guess what we're discussing? We're discussing musculoskeletal disorders. One thing I wanted to review anatomically is the spine, because we're going to talk about neck injuries today. So there's a couple of things that we just wanted to review from anatomy. First of all, the spinal column is made up of individual bones, and they are called what? Vertebrae. Thank you very much.
the first part of the spine is the cervical vertebrae, and that articulates with the occipital bone of the skull and forms a pivot joint that keeps it on your body. Yes, it does. The pivot joint articulates this with the axis there that is found on the second cervical vertebrae. The thoracic vertebrae articulate with the posterior ends of the ribs, and the lumbar vertebrae are the largest and the strongest, and the sacrum articulates with the os coxae at the sacroiliac joints. And so the coccyx will serve as an attachment point for several different muscles of the perineum. And then the vertebrae forms a flexible backbone, and it can do this because of the discs that are in between these vertebrae that are cushioned, and they are allowed the spine to bend. We got this? We got this. Now, the thing about this is over here on this picture, you can see that there are 7 cervical vertebrae. There are 12 thoracic vertebrae. Now, the 12th thoracic vertebrae really move the least. So very rarely are you going to see back strain or any ligament damage to this area of the spine. And then the lumbar vertebrae, as said earlier, are the largest. There's 5 of them. And then the sacrum, and then the coccyx. Now, whoops, there goes the dementia again. Totally forgot what I was going to say. I know, it just happens, people. Get a grip. Where is my cursor? There it is. I saw it. Here we go. So, when you start your initial assessment of the musculoskeletal system, you're going to begin with a history and say, so what is your either Mark's taking Xanax or no dose to stay awake. I don't know. He's over there just popping those pills like candy. Okay, so you're going to ask the patient, why are you here? What's wrong? And you are going to ask them to describe the location and the pain area where it's at. You're going to ask them to rate their pain. One of the things I was noticing that was written somewhere in the quiz or the exam, can't remember where, was that you have your little caldera going on there, which is your characteristics, your onset, your location, your duration, caldera, your exacerbations, your radiations, your relief, and your associated signs and symptoms. But there's going to be some kind of synonymous description of those different things. So if you were to describe characteristic of pain, what is another word that you could use for that? If you're going to talk about the severity of pain, what are you going to use as part of your pain assessment for that word, severity? So I would just play with that a little bit if you want. It's all up to you, people. It's all up to you. So the techniques that we're going to use when we start the physical assessment are inspection, palpation, and range of motion. And we usually start with their gait. Sometimes this can be noticeable. You're going to, as your technique develops, as your experience increases, you're going to learn to multitask. So some of these things, so many things, the neurological assessment, can be done when the patient enters the room. You don't even, have to say, I'm going to start with a neuro assessment and ask some questions. You can talk to them as they're coming into the room. You can talk to you can see how coherent they are, if they're very articulate. It's the same thing with musculoskeletal. When you see them enter the room, there's several things that you're going to be looking at and assessing, not necessarily having to ask them to get up and walk across the room later. So when you see them, the first thing that you're going to look at is their gait. And you want to inspect their posture. Number one, are they erect? Are they hunched over? Are they leaning forward? We want to note their gait. We want to know that if there's any alteration in movement, such as limping. Also, and this is required in your documentation, is are they using any mobile assist devices? And if they are, what is it? And how long have they been using those assist devices? And be very specific. Is it a cane? Is it a walker? Is it crutches? You also need to document any gross deformities, such as an amputated limb, or if there's malalignment in the hips. You can look at the hips. It's amazing. As a nurse, you start noticing this at the mall. Are those hips uneven of that person in front of me because they're walking so slow? You kind of see a little tilt in the hips there. Also, if there's any contractures, of course, that are pretty noticeable immediately. You want to also, as part of the musculoskeletal assessment, assess the joints and the muscles of the arms and the hands and the legs and the feet. What we're looking for is when we move those joints, do you hear any grating? Do you hear any cracking? Is there any pain involvement? Where exactly is the pain coming from? When I had a meniscus tear, the physician was, I went in and said, I have knee pain here. And so he's going, does it hurt here? Does he hurt here? Does it hurt here? And he'd push these different spots. And then when I kicked him right in the groin, oh, it hurts there. Yes, it does. So stop pushing. But he knew exactly what area when he was pushing, what that was indicated for, what area of the knee had been injured. After you do your physical assessment, you want to inspect the warmth of the injured area, any tenderness. Is there any swelling in the area? And if they've had reddened joints and that are very tender to touch, and you want to feel that area very, very gently and tenderly and see if you feel any bony prominences, any bony nodules there. And you're also going to want to observe the joint mobility. So you want to stabilize the area that is proximal to the area of pain. And then have the patient move the joint for the distal end of that extremity. And you want to observe the patient's reaction when they move. Is it severe? Is there a lot of grimacing? Or they just say, yeah, that hurts? Yeah, you have to, again, use your judgment and determine what their level of discomfort is. So basically, we've talked a lot about some of these things. One of the things that I wanted to remind you all is about spinal curvatures. This is a good posture. This is an upright posture. This is where you have a forward movement. A lot of times you'll see this with Parkinson's patients where they're leaning forward. It's a neurological thing. It's the most interesting thing because it's not necessarily they had an injury at all. But neurologically, their brain function or cognitive function is beginning to deteriorate, and they don't recognize that they're having this forward head that propels them forward, sometimes faster than they can walk, and their gait is very short, so that it's a shuffling motion that they have. You also may look at curvature of the spine, and this is kyphosis. This is different than what you see when you have a patient that has Cushing's disease and has a buffalo hump. The buffalo hump is a pad of fat that's a little bit higher that comes just off the first couple or three of the cervical vertebrae, kyphosis starts more towards the upper thoracic region, and they have sometimes what is referred to as a hunchback for this kyphosa. Then you have this lordosis, which is a sway back. So in the sway, did you know that little kids don't develop this sway in the back of the spine until in the lower portion of the spine until they begin to walk? And then when they begin to walk, they start developing that to maintain balance. So some overdevelop and the person ends up with a sway back, and then you have, or not, this is lordosis, this is sway back, sorry. Lordosis is the significant sway back, and then lordosis is the lower spine. Let's just talk, I say sway back, and it's what the definition of this is, so it's confusing. So this is lordosis, where you have an exaggerated curve or bow to the spine. The sway back is more where they're tilted backwards. The picture clarifies everything. So we talked about the rest there. Okay, so this, if you'll remember from your comprehensive health assessment, is motor strength. How strong is their grip? So you want them to extend their hands and give you their first two fingers, and then you hold those two fingers and have them pull you in both directions. And you want to give them some resistance there. And that is done in both upper and lower extremities. And then you have your range of motions. Now, I'll be frank with you guys. Why? Because I love you. And so I'm going to tell you outright, there's 3 or 4 questions on there about range of motions so that you can be able to, just like in the quiz, recognize what the names are. Because when you are documenting, you have to call the actions that you see correctly and accurately. And if you don't document that accurately, the doctor is you're going to just lose your credibility right down the drain. So if I trusted myself with the software, I would demonstrate this for you, but I don't. So I'm not going to get out and show this to you. You all know what they are. You've been doing it since you got your CNA. So just refresh on that a little bit. All right, so also we're going to look at neurovascular checks when you have an orthopedic involvement or when you have a joint involvement. And quite frankly, I do it when there's any kind of tissue trauma to an extremity. That's what I do, but for the record, this is neurovascular checks are done for orthopedic patients. Now, I have to just recommend as a strategy when you're taking the exam that you read the exam carefully, because many students get neurological mixed up with neurovascular. Now, if a patient comes in that has a head trauma and has a broken femur, which one is going to get the neurovascular check? The femur. But some students are just reading that old question there because they're anxious to get through, and there may be a question on there about neurological, because in a motor vehicle accident, it can be either or. Or if you're walking down the street and get the shit beat out of you, it can be either or. But know what you're assessing and use the correct terminology. Is it a head injury? It's going to be neurovascular. Are you going to do the Glasgow Coma scale with a head injury? Yes. Are you going to do CMS with a orthopedic injury? Yes. So be very careful when you're reading questions. So what are we going to use for a neurological assessment? What are the questions? This was clear back at your comprehensive health assessment. Do you know where you are? Person, place, and time. What else? Perla. What else? What about judgment? What about memory? What about calculations? Remember everything that is involved in a neurological assessment, but also recognize that you have to use the Glasgow Coma Scale for a non-responsive patient. Okay. I think I covered that. Okay, so also, if you have a patient that comes in, for example, that has had a cervical injury, cervical. So where are you going to do a CMS check?
Whole body, man.
On the face? Distal, away from, downward. So we're looking at all four extremities. We're going to do all four extremities. But if somebody comes in with a herniated lumbar injury, the legs, the lower extremity, always distal, downward, away from the injury. Again, when you're taking test questions, read the scenario thoroughly so you know what to assess. All right, so this is the thing about neck injuries, and this is the thing about lumbar injuries as well, lower back injuries, is that there's three types of injuries. This is true for both kinds of injuries. There's either going to be a muscle strain or spasm, there's going to be a ligament strain, or there's going to be disc degeneration or herniation. So when you go to the gym, which I'm sure we all do frequently, daily, and we're working out and building up those muscles, and you come home and you have sore muscles, what's happened? That's exactly right. It's lactic acid buildup. It's a byproduct of muscle breakdown there. So you have to, what do you have to do to get rid of that lactic acid? You may not want to do it. You may not feel like it because your muscles are sore. So what do you have to do? Pardon me? Stretch. You have to move those muscles. And you have to drink you have to increase your fluid intake to flush that lactic acid out. I don't know if you've ever watched Michael Phelps or the Olympics in swimming, but you'll see that after they do one of their feats or meet?
M-E-E-T.
Where they do a meet with their feet. No, one of their meets is that they get out of the Olympic pool and there are lanes where they have just swam for the meet, and they go to another pool and they swim a few very slow laps to get rid of that lactic acid. It's a cool down. And so that's what happens when you have a muscle, a slight muscle strain that hurts because you worked out too much, you overused them, and so you have a buildup of lactic acid. So what we're going to do is move, and we're going to increase our fluid intake. So if this can also happen, cause muscle spasms. And so what we want to do for this is as soon as we get them to calm down with their pain a little bit after they've done that, is we want to do muscle strengthening exercises. Muscle strengthening exercises are not necessarily lifting weights. They are against resistance. It's so that slowly and gently increases their strength. With a ligament sprain, we're a little bit more concerned because the ligament is attached to the bone, holding it in place. So if you have a ligament sprain along the cervical spine, is this of any concern? Yes, it is. Why? Because it is putting strain or pressure onto that bone and can cause it to malalign. And then you're going to be in trouble because that's going to be putting pressure onto the spinal cord itself. So when you have a ligament sprain, it's a little bit more acute. It requires that a person is put usually with a brace. Now, if there is some kind of injury, like a herniation to the cervical spine area, where the disc between the vertebrae has now that little portion, and we're going to talk about this in just a minute, ruptures and starts to ooze out a little bit, it's going to put pressure on the spinal cord. Now, the problem with spinal cord having pressure on it is twofold. Number one, it's going to hurt like hell. And number two is that if it's not relieved, it is going to damage that nerve to the point of death. It literally can kill the nerve. The nerve will no longer function because of compression, just like anything else in the body. Those nerves require nutrients and oxygen, and if we're not going to feed it because of compression, then it's going to become ischemic and potentially die. And cause permanent damage. So we have to hold everything in place, and we can do that by using a neck brace or a halo traction. How many know of what a halo traction is? Ever seen this? It's really, yeah. It is basically external traction where a person will wear kind of a chest plate, and then there will be these steel rods that go up to the forehead, and then the rods will be drilled in to the level of to become flush with the skull, a little bit into the skull to the bone, so that the neck cannot move at all. These are some people that either have a broken neck or they are but the spinal cord isn't damaged yet, or there's been some kind of serious ligament tear or damage. And we put them in a halo traction so that that ligament or those bones can heal and not damage the spinal cord. So with ligaments, you're going to have a brace. If it's at the neck area, you can either have a neck brace or halo traction. If it's in the lower back region, you're going to have a back brace. Again, to hold that ligament in place so it doesn't do any more damage. Now, what happens when you have a brace on? What happens to the muscles that are surrounding that ligament? They start to atrophy a little bit. They weaken. They become deconditioned. So you have to do these muscle strengthening exercises to get them strong enough to hold the head in place or hold the body in place. Okay? All right, and then with disc degeneration or herniation, we need to get that controlled really fast. And we'll do that. Again, what we're having here is that let's just look at our next slide. Because this shows a picture of herniation here. So here you have these cushion or these discs in between the vertebral bone. And these discs have this really firm outside area here, which is the annulus, and then you have this inside area here. Oh, sorry. Let me go back. So you have this inside area here that can, this area can get torn, the annulus can here can get torn, and this little soft gel-like material can begin to ooze out. And look at, this is the spinal cord right here. So now this gel-like material is putting pressure on the spinal cord right here, which is going to send pain out to the nerve roots here, which can travel clear down the leg. So the thing about it is, if this is in the lower back, if you have a herniated disc, it's not only going to potentially affect the spinal cord, but that spinal cord is going to cause pain to travel down the length of the roots that extend out of the cord at that level. So you're talking like sciatica pain for lower back pain. Yes, ma'am.
So I just have to ask you, like, how do you tell the difference between a herniated disc or a sciatic, and which one is? Like,
one is causing the other.
One is causing
The disc, the herniated disc, is causing the sciatic pain.
So would you have to get your sciatic, like the herniated disc, fixed?
Yes.
Does it cause
Yes.
damage to the spinal cord?
Yes, and you need to get it taken care of as soon as possible. Now, there's some ways that they can do that.
Is it just like continuous pain?
Is it what?
Is it continuous? Like it doesn't have any relief, even if you stretch it, whatever? Okay, so I don't have a herniated disc. Never mind.
But
You were scared.
let me just talk to you a minute about. This can be just, sorry people at home, my mouth was dry, so I just took a big old bite of ice. I don't know, can you hear me chewing ice? Okay, so the thing about it is the amount of gel that goes out and puts pressure on the spinal cord here can vary. So it can be a little bit or it can be a whole lot. Now, if they're putting pressure there, it's going to inflame the root. Now, sometimes insurance companies will manipulate the doctors and say, well, they have to do a series of cortisone shots for 3 times before we're going to even consider surgery. And even if the physician knows this is too bad, he's looking at the MRI, he's looking at the CAT scan, he knows this is too bad, this is a really bad rupture here, then he may have to do what the insurance companies require. Did they just tell you to put your mask on? Oh, okay. Because
It was important.
No, you did look important.
Okay. Okay, so the thing about it is that they may require that first. But again, it depends on how much of this gel-like material is compressing that nerve. Okay, so it can be a little, it can be a lot. But once it's been injured, you know, it potentially can happen again. With a hurting bulging, it can be bulging. It's going to hurt, but it's not going to be putting a lot of pressure on the spinal cord as if it had literally gone ahead and herniated. So what you're going to find is that if this is in the upper neck region, it's going to hurt to move their neck in any direction. In fact, you'll see people moving their whole bodies, turning their whole bodies instead of their neck because they can't move their neck because it hurts so bad. And sometimes it will radiate down the arm. and it will radiate down the shoulder and then down the arm on the side that the herniation is on. It can be so painful that it interrupts sleep when you try to change position. It can cause a headache because the pain is so severe, and it can cause numbness and tingling. And that is, in fact, the clue that you're looking for when you have a person that comes in complaining of neck pain or lower back pain. So you're assessing that pain there. You're looking for the location of it. But then as part of that caldera, don't you ask, does it radiate? And you say, my whole leg is tingling. If the whole leg is tingling, if anything in that extremity is tingling and has numbness to it, then you know that there is pressure on the spinal column. It's a nerve thing. If they can move and it just hurts where they have maybe sprained or strained that muscle, then it's just muscle. But if there's tingling and pain associated with it, then it involves herniation or bulging of the disc.
Does it always require surgery for like a bulging disc?
No, not always. But, you know, it all depends. It just is, the doctor knows. The doctor knows. All right, so here's the thing that we do when you have a muscle strain or sprain is we want to do strengthening exercises. You're going to do this if you have a ligament strain or sprain. You're going to do this if you have a muscle strain or sprain. We've got to strengthen those muscles so that it doesn't happen again. Another thing that will really help tremendously, especially with a ligament sprain, is that the body is in correct body alignment. So here's the deal, whether you recognize it or not. Some of these things maybe you'll recognize because you're bringing it to conscious thought processes, but most people who don't have a health background usually just accept it for what it is. And that is, if you twist a little bit away, oh, that hurts like the devil. And why does it hurt like the devil? It's because you are not aligned and you're requiring that injured muscle to be used to accommodate the position of the body. Now, as a CNA, you probably learned a lot about body alignment. When you leave your patient, you should have them in correct body alignment. The shoulders and the hips should be in perfect alignment. Why? Because if you have it twisted, just even a little bit, then you're going to go out of the room, see if the patient needs a call light, all that kind of stuff. You're going to leave, and 10, 15 minutes later, the patient's going to be on the call light saying, I'm uncomfortable, I need a repositioning. And it's because that tiny little muscle that's going around the middle of the back or the upper back causes that muscle to become tired. And so they're uncomfortable and they reposition themselves or need help with repositioning. So that's why it's so important with any kind of injury along the spine, whether it's muscle or ligament, that the body is in good alignment so that those muscles are at rest. They're not being used. So that is the non-surgical management. That is true for any kind of injury you have along the spine, whether it's muscle or it's ligament. However, sometimes when we get a degeneration of the vertebrae itself, or there has been a bulging of a disc, then we may need to surgically go in and correct it. And we're going to do that by the ACDF method. You're going to see that charted all the time, ACDF, which basically means the anterior cervical discectomy and fusion. Or they may opt for a minimally invasive surgery, which is doesn't require a hospital stay. It's a outpatient surgery. Usually the patient goes home the very same day. So let's talk about those two options there. So before we talk, I do want to emphasize the fact that we're going to talk about surgery here of the neck. And the interventions and the signs and symptoms that we need to look for and the complications are going to be the same, whether we're doing an ACDF or we're doing a thyroidectomy or we're doing a lump removal, any one of those things. We need to remember that this kind of surgery, the interventions, the complications, the signs and symptoms that you need to be looking for are going to be the same. So the reasons for neck surgery, as I said, can be the ACDF, the thyroid surgery, cancer. There can be other things going on. But post-operative interventions have to do with assessing the following things, because there are some very vital pieces of equipment within our neck that we've got to be very careful for. And with any kind of incision, what are you going to have? Risk for infection, but breathing, yes, you're going to have big problems because of inflammation. Anytime there's an incision, a laceration, any kind of wound, part of the healing process is inflammation. Inflammation brings edema with it. Edema, acidemia, can cause compression onto the trachea. And we need that trachea to breathe. So there's also, if it's a thyroidectomy, there's some major blood vessels there that can become compressed because of inflammation. So with any kind of neck surgery, we want to always make airway, breathing, and circulation number one. Number one intervention. So on any surgery, any scenario that you see on a test question, you're always looking for data about airway, breathing, and circulation. So the thing about it is, if we do an ACDF, let's talk about that. The thyroid's going to be done anteriorly as well. And so what happens here is that the incision is anterior aspect of the neck. So I finish up here as the surgeon and I slap a dressing on there and I leave. And I take the patient, or somebody takes the patient up to the surgical floor, and I've got this nice clean white dressing on here. We know as nurses that assess surgical patients, what do? We lift the dressing to make sure that it's clean and dry, to see if there's any kind of drainage coming from the incision, make sure that the incision is well approximated. But with a surgical incision on the anterior aspect of the neck, what do we need to consider? The person is laying supine. Somebody's moving their desk. Patient is supine. Where's the blood going to go? Patient supine. It's going to go to the back. Exactly. So this happened to a friend of mine. that worked the pediatric unit, and boy, she was so mad because they were full. It was a winter season. It's full. Pediatrics always goes up in the winter because of respiratory problems. So she gets this patient, and she from the emergency room, and the emergency room called her up and say, "Well, we're bringing up a patient," and the nurse says, "I have every bed full. What am I supposed to do?" And I said, "Well, you got to put her somewhere because we've already got her in the elevator." So she takes her into the procedure room that is on the floor, the pediatric floor, and she brings in the patient, and the orderlies leave. The transporters leave. So she's doing her baseline assessment on a patient that she has just received that had been in a motor vehicle accident. And the report that she had gotten from the ER was that this was a stable patient. So she's doing her assessment on this patient and turns the patient over, and the patient is lying in a pool of blood.
Oh, Jesus.
Oh. So the thing about that's exactly right. It's this is not a stable patient. This isn't what you promised. But nobody had bothered to look, or the nurse who was down in the ER didn't bother to look after they stabilized the patient. There's no doubt that they did that down there. But the patient was supine, laying on their back, and for whatever reason, didn't do a check of the back. Because when I say pool, I mean a pool of blood. So again, this can happen with neck surgeries. The blood gravity will pull that blood or any kind of drainage from the incision to the back of the neck. And so as a nurse who's been assigned 5 patients to assess and is responsible for, just looking at a dry white dressing on the anterior aspect of the neck does not mean that person is not draining blood or some other kind of drainage, exudate from that site. So whenever you're assessing a person that has had an anterior neck surgery with the incision in the front of the neck, you need to check the back of the neck as well. Check for swallowing disabilities, again, because of excess inflammation can cause edema that can put pressure on the esophagus. Monitor vital signs and the neurologic status frequently. Monitor for hoarseness. Again, there can be some injury due to the incision and the inflammation process. Assess the patient's ability to void. What the heck are we talking about here? Assess the patient's ability to void. Why the heck are we talking about that when we're talking about the neck? I love this because as far as what I'm getting is, well, I can't understand you. So I just assume it's correct. It's correct. That's correct. But the person, number one, has been under general anesthesia. We always check for urinary retention when a person's been under anesthesia. But with an ACDF, what are you doing? You're fooling around with the nerves, aren't you? With the spinal cord here. The spinal cord doesn't have to be severed to cause dysfunction. It can be damaged, it can be torn. There can be things that can be going on there that we did not recognize while the surgery was still going on. So we always want to assess the patient's ability to void for 2 reasons. Number one, they've been under general anesthesia. And number 2, we're up at the neck, that any kind of injury to the spinal cord can cause damage to that bladder sphincter. monitor intake and output, manage the pain, and assist the patient with ambulation within a few hours of surgery. There have been monumental changes because of research that has been done, and getting a person up and moving is plays a huge influence on how fast they will heal or if complications will develop. All right, let's finish this up and then we will take a little break. So discectomy surgeries are typically minimally invasive. So what they'll do here, when we're talking about a discectomy, we're either taking out a portion that has been torn, the outer ridge, or we'll go in there and suck some of that little gel-like material out to get the pressure off the spinal cord. And they can make it a very minimally invasive surgery. They can go in, they'll only put in like a little inch of an incision right next to the disc where they want to go in. They'll just go in with little tools, make it all happen, sew it back up, and a couple hours later, you are discharged to go home. But when you have more invasive back surgery that are typical with degeneration of the vertebrae, then you have to fuse several discs together. You stop the movement of that portion of the spine because we're going to fuse those discs together because the cushions are basically gone. So there is higher risk that's involved there. It does require hospitalization and careful monitoring for complications because we are manipulating the bone that protects the spinal column. So let us pray. Let us take a break until 5 after 11. And I'm not turning this off because why? Because I'm afraid I won't get it back. So no swearing anybody during the break. No obscenities. No vulgar jokes. Nothing during the break. And come back at 5 after 11. Kind of gets my jokes.
I like getting the vaccine.
Oh, God. Well, that got me freaking out.
You have leg pain.
I have sciatic pain like bad. Like to the
You
point
need to
where
go get it. No.
Let's operate.
When was the last time you went to the house about it?
never. So it
How long has it been going on?
almost a year. But I haven't done anything to try to alleviate it. Like I haven't done like yoga, which people told me to do. I haven't tried to stretch it. Every now and then I'll stretch it.
You can do it. Or you're going to feel like this the rest of your life. So you need to go get it.
If you get pregnant, that's so.
I had, I just had a PN1 student that herniated the disc. So it's doesn't, you don't have to be old to have it happen. It can happen at any time for anything. So
That's usually when I like kind of exert myself. So I don't know if it's just like the piriformis pressing on my sciatic or if it is a disc. Because like I'm fine, I can do things, but there's some days where I'll get up and I'll go to put my freaking pants on and just standing on this leg, I'm like,
you need to go get it looked at. I'm serious.
I think because I don't have time for surgery.
I know. Well, you don't, but you know, they can give you a cortisone shot to reduce the inflammation, which is obviously putting pressure on it.
Yeah.
And the thing about it is that I think that would control it somewhat because it's not constant.
Yeah.
If it was constant pain, there's constant pressure on it. So, you know, that it comes and goes means that you probably have a bulging disc. And talk to them about. I know.
shots.
Who does?
I mean, I'm able to do things, like I can still do like my pistol squats that I do at the gym with no problem.
You know what I would do if I did that? I would be down on the floor and nobody could get me up. Nobody could get me up.
I used
They'd
to
just
do
all be looking at me.
Man, it hurts so bad.
I used to pull over.
Oh, no.
The doctors like got me trying to do yoga. I'm like, I can't do this.
Do you have back problems?
I'm starting to, yeah. You know, I've always used my back the right way, and I've always lifted the right way.
Oh yeah, always. Yeah, I've never like turned to grab a patient like this ever.
Back injuries are the #1 reasons why nurses leave the profession.
I know, but and it does go like the whole length of my leg. It'll go down my butt, across my freaking leg,
Yes.
and I do get tingling in my feet every now and then, and that freaks me out. I'll be
Good.
exercising.
It hurts.
I'll be exercising on like the elliptical or something, and I'll be like, why are my feet numb? I got some problems. I don't know. What's wrong?
You know, like over December, I'm really gonna get back to chiropractor. This whole year just screw everything up.
Sure to
Like
low-key
school
don't,
is the easy part.
I low-key don't trust
No, I don't either.
chiropractic.
I don't until they crack it. I'm like, oh, that's amazing.
Yeah, I'll crack my own back in a way that I know won't paralyze me. Let me go that one person that one time. It's like, oh,
Oh, we had a guy that came in,
Sorry.
he brought his kid into the ER. I don't want to give you names or anything like that. He was a practicing chiropractor, and we call him Child Protective Services. He thinks he's like a straight up doctor, like giving his kid like medication, withholding prescribed medications and stuff. We had to admit his kid, and our doctor like called him yes because he's putting this kid in danger. We were like, which chiropractor is that? And I'm like, oh,
yes.
No, that's, of course, I haven't ever used any of them, so I don't know what they are here. I just know back in Oklahoma, they did have that tendency to. What is the word I'm trying to look up? Treat anything. Don't
Yeah, they
treat
overreach their
anything.
scope.
Yes.
Yeah.
Yeah, exactly. And no, you just can't do that.
Oh, my grandpa, bless his heart. He's always like, whenever he gets sick, he's like, I'm going to the chiropractor.
Yeah.
He'd have a 4-year-old be like, I'm going to the chiropractor. Grandpa,
The same cousin I was talking about that's just super anti-vax and all that. She like we used to work for a chiropractor. And she's like, we take your babies to the chiropractor and stuff because they're like, oh, it'll heal everything. Like,
no.
I have allergies. Like, I do believe like certain manipulations of the spine can help with certain things, but no, it's not a cure-all.
Yeah.
Gotta be done very carefully. I was like, I don't get how people do it all the time either. It sounds like a lot of trauma.
Dude, I have that shirt. Do you? Yeah. I love this shirt so much.
That's it.
Classic.
It's a Stormtrooper Starry
I
Night.
just went on a walkabout. Every PM1 student is in there. There's like 3 of us.
Yeah. Jeez, did they not watch the?
I was going to say, I was wondering if that's why so many people stayed home today was because of Governor Herbert's thing.
It's just a whole
Maybe.
Yeah, it's on. It's being recorded. I said it.
Like, just wear your damn mask. You'll be fine.
We're professionals that tell us that blah blah blah. Yeah, please. You put your these panties on your face. That's gonna save you.
How high were the cases on Saturday? It must have
We
been.
didn't hit 3,000. I thought we
Is that it? What is that? What it
Yeah,
did?
it was like right around there.
No, it wasn't. It was less than.
Yeah, it's less than 3,000.
We were like 56 away from 3,000.
Oh, really?
We were gonna hit it. I was pumped. We're gonna do records.
Well, I just don't know why they waited till now. I mean, you know, I would have thought that maybe even a week ago, but I don't know what the hesitation. I don't know if the election had something to do with
Oh,
it
it totally did.
because,
It didn't have Spencer Cox losing.
well,
What about Spencer Cox?
because he's lieutenant governor, so it's Herbert's stepping down.
Oh, I
And,
know.
yeah, so like you can't go throw a mask mandate in right before the election.
I was thinking more if it was, I don't know if Trump was putting any pressure on the governors to not mandate masks.
Who knows?
The thing that's annoying about it, well, not annoying, also like exciting, is the KSL comments, dude. They're nuts.
They're so funny.
They are insane.
I
That's the
never
first-
watched them.
That's the first thing I did last night. Was I went on KSR
I
to
mean,
read
yeah, I don't
comments.
even read the article. I just read the comments.
Yeah. They have to like shut the comments down like an
I know,
hour
it
into
gets
it.
to a point where it's like, no further comments.
Yeah.
It's always that one case mom who ruins it for
Yep.
everyone.
He's Karen.
And my favorite too is that people are like, I'm not wearing a mask.
Okay.
Stay home. Like, sit at home.
That's how I feel. Like, I don't want to wear masks. So I told Cassie last night, like, guess I'm staying home.
Yeah, like,
Well, but
Whatever.
there weren't any consequences for the gatherings. There was a $10,000 fine, but there weren't any consequences for people that didn't wear masks.
Well, he's kind of fuck her now. Oh my gosh. I think of words. Anyways, he would say like, well, you can't do this, this, and this, but we're not stopping this, this, and this. I'm like,
yeah.
but you
Yeah.
just said we can't do that. Like, you don't go to church,
Mhm.
but you can still worship.
But,
I'm like, what?
yeah.
Like, what?
Do we have to get tested every week? Do we fall under that category?
I was wondering the same thing.
Yeah,
I don't know.
because we're not at university.
But I coach high school basketball, and it was supposed to start today, and it got canceled. We can't start until the 23rd now.
Yeah, they're only allowing college football and high school playoffs.
Yeah.
It's like,
Did you not hear Governor Herbert's?
Oh, you didn't hear it last
No,
night?
I'm like
It was.
away from politics because it doesn't
You
make
didn't
me
get your
happy.
emergency
So-
alert?
They didn't get the emergency alert last night.
I
It was
didn't know
9:30.
that shit. I like
People were so mad about that too.
I kind of get it though because of that.
But
Like,
people didn't understand. Like, they were like, don't send me an Amber Alert. It's not an Amber Alert.
yeah, it's the emergency
It's
broadcast
an emergency
system.
alert.
Yeah.
Like, so, it's not, no kid's gone missing.
Yeah, so like yeah, the
We're
universities
not
and
worried about
stuff,
the children.
they're getting like weekly testing now.
So if we go to Weaver State next
Semester, you'll get weekly tested.
Yeah,
No,
well,
it's
it's for the
just-
next 2 weeks. Next 2 weeks, and then it'll be 2 weeks again. And it'll be just like it was back in like May. It'll be 2 weeks, 2 weeks, until who knows.
I hope it's the spit
But
test.
see, the thing is that they said that afterwards, and this may be the contraindication again, was the universities don't have the tests available or the personalities to have their students do that, so they can't start it until still January.
But yeah, they just talk about like the National Guard and all this stuff. It's like, geez, man.
What's
I want to
happening?
get back to where we can't go to Plymouth. Bring out.
No, I don't want to do clinical assignments.
Okay, it's too bad that you aren't here with this riveting discussion on COVID. I hope you picked up on it at least, and we're writing something, contributing, although I can't see it because I'm not cutting off the screen because I'm afraid that if I do, we won't get it back. All right, let's start picking up on discharge teaching, and this is specific to somebody that has an anterior cervical disc fusion. And you can see the rationale for this, I'm sure, and that is number one is to have someone stay with the patient the first few days after surgery. So why do you think that's necessary? Why can they go south?
Well, A, surgery, get honesty, but B, they just had like cervical surgery.
So how long does inflammation process
48 hours.
go? You know, it's for the first 48 to 36 hours. And so we want somebody there that whole time in case there's any kind of inflammation that may start causing them with some of the problems that we saw in the previous slide. Okay, we also want to go over their medication prescriptions with them. We want them to teach them to take care of the incision. What do you think some of the guidelines are going to be for bathing?
Post-op, they do or something. shower.
Yeah, first of all, they're not going to have you shower the first day you get out of surgery, but they're going to have you shower hopefully and not, around the back and not face. Don't let the incision get right under the flow of water, basically, is what I'm trying to say. You don't bathe and you try to not get under the incision in front of the water.
Does that have waterproof bandage?
They do. They have like Tegaderm that can put on it and protect it. Review the activity restrictions. Now, why do we have no lifting? What is that? Again, this is the neck that we're talking about. Why does lifting have anything to do with it?
You're still putting strain on your neck.
You're putting stress on the incision, exactly. And there's a potential also, not only for the incision side, but you have the potential of reherniation or reherniating the disc. Okay? No driving until the physician gives permission, because they are going to be on pretty strong medications. No strenuous activity. Now let's talk about those medications. Do you think if the person has had lower back, now we're talking about ACDFs right now, but if we were talking about a lumbar surgery here, what kind of medication do you think that the patient has been on for a couple of months before they go into surgery? Opioids, exactly. And there may be some kind of addiction that is associated with the opioids because they've been on them for a month or a month and a half or 2 months before the surgery. Remember, the insurance is requiring that the person get steroid shots before they go in for the surgical procedure. So there may need to be, not necessarily with the ACDF, so don't get confused on that, but with with the medications for the lower neck, the ACDF, we're talking about they'll probably get into surgery a lot faster than lower back herniations. But we can't just stop somebody that's been on opioids for a month and a half, or 2 months. They've got to wean themselves off those medications, okay? So we want them to walk every day. We want them to wear their brace collar per the surgeon's prescription for their neck support. And then we want them to call the doctor if the tingling persists. Now, if you relieve that pressure off the spinal cord, then there may be some residual tingling and numbness right after surgery. But if it persists or gets worse after 24 hours, I would definitely call the physician. And if the swelling gets difficult. So just tell them that, with the kind of damage or the pressure that has been on these nerves on the spinal cord for a period of time, it may still hurt a little bit immediately after surgery, but they should start feeling better pretty soon. All right. Okay, what is the nurse's priority assessment for a patient after cervical discectomy, and fusion surgery? So they're missing, I would guess. I don't know why I wrote it that way. So assess for bleeding underneath the back of the neck, assess for difficulty swallowing, monitor for hoarseness related to laryngeal injury, or monitor for swelling and maintain the airway. These are kind of questions, I hate these kind of questions because all those answers are right, aren't they? You have to do all of those. But what did Mark Medina tell us when we were talking about assessing post-operatively? Airway,
Yeah,
airway,
ABCs.
airway, airway.
Yep.
ABCs, always ABCs are first. All right, the nurse is providing discharge teaching for a patient following a cervical disectomy. All of the following principles should be taught, except someone needs to stay with the patient for the first few days after surgery. Incision may get wet as long as it's clean water. Activity restrictions of no lifting, no driving, no strenuous activity. And report symptoms of pain, numbness, tingling, increased pain, or difficulty swallowing.
3 and 4.
Except. So, yeah, it's that tiny little word. But this would be a select all that apply question. And you would choose one. I mean, you choose those 3. All right, let's go on to low back pain. We talked about cervical pain or cervical injury or pain. The big thing about back injuries is that a large majority of them are preventable. So it's necessary that when you have someone sitting on the front row in the classroom that has experienced some kind of back pain, then this is some teaching that you want to give the person, patient education. So we need to use proper body mechanics. Now here's the deal about proper body mechanics, and this happened back in the 90s. So that we had back pain was the number one reason why nurses were leaving the profession. And there was becoming a nursing shortage that was affecting the entire country. So the American Nurse Association did a lot of research, and they found that the rules body mechanics, which are a part of every nursing curriculum, starting at the CNA level, were pretty basic, and they're still good. It's not that they're bad. They are still applicable, but they were limited to a man carrying a 50-pound box. That's it. And so we know that as nurses that our task includes so much more and much more frequency of carrying a 50-pound box across the room. So they came up with a new campaign for nursing called Safe Patient Handling. And they came up with a scenario, not a scenario, but kind of a slogan as their mantra, which was manually moving a patient only if it's absolutely necessary. So the thing about it is that they have created all these and developed all these assist devices when you're moving your patient, so it minimizes the lift, the manual lift. They have sheets, they kind of like a parachute material that you can slide patients very easily. You can slide a 300-pound patient with 2 fingers anywhere on the bed. If you're using those sheets. They have, when my daughter was having surgery at Ogden Regional, they had these air-filled mattress type things. Had I known they were the patients when she was transferred over from the surgical to the med floor, I would have taken it with me and washed it and cleaned it when I got home so I could show you guys. But it's an airtight mattress that makes repositioning the patient so much easier. For hair, it's called what?
Air taps.
Air tops. There you go.
Taps, but yeah.
Air taps. So also with heavier patients that can cause back injury when you're just assisting them to stand. There are gait belts. There are steadies. How many of you know what a steady is? Oh my gosh, they're the most fabulous things ever because it's pretty much like a walker, but they can use it to walk themselves to the bathroom, and then you lock it and they can turn around and sit, and it holds them on the toilet. What is it? What do you call it?
Those are the best.
Oh, those are the best. You can use it when they're ambulating around the station. It can hold their Foley bag. It can do it. It's wonderful, but it allows them independence and steadies their gait. So they have all these new assist devices for this safe patient handling campaign. So we do want to not discredit proper body mechanics, but just recognize they're the basic foundation. It's not the only thing you use as a nurse anymore. And you're the only one that's going to protect your back. You are the only one that is going to protect your back. And I have to tell you this, and I hate to be harsh, and this is reality, but if the back gets hurt, if your back gets hurt, they will try and put you in another position for a month or so, but they are not required to keep you. Yeah, that's how good. You give your back to them. No, I'm just kidding. Okay. Avoid prolonged sitting and standing. Get assistance with household chores and other activities if needed. Participate in regular exercise program that strengthens the back. Again, what is the number one intervention we're going to do is muscle strengthening. Muscle strengthening. Swimming or walking causes less strain on the back. Do not wear high heels. Mark? What? Mark? I know.
Make them pop.
Maintain ideal weight and stop your smoking. Pete's sakes. All right, so what is
Vicki?
Hello?
Hi. Yeah, I'm online.
Oh, yes.
I just have kind of a weird question because it seems like every single unit or every single module that we've learned about, the answer is always to stop smoking, like
Yes,
every single time.
Yes,
So why is it that we have not regulated that? Like when vaping was so huge, like lawmakers got really involved and we're going to outlaw it and we're going to limit the accessibility and all this stuff, right? Why has that never happened with tobacco products?
Too much money in it. And I hate to tell you that, but it's true. The tobacco industry has a huge PAC donation to legislatures in Washington and really in every state. Whenever money's involved, you're going to see a legal thing around it. There wasn't that much money in vaping as of yet. And there were some significant enough problems that people were dying relatively in a short period of time. With smoking, it takes a long time for emphysema to develop or cancer to develop, type of thing. With vaping, people started having respiratory issues and were dying and were becoming critically ill in a very short period of time. A lot of teenagers were struggling with that. But I guarantee you, we do have stop smoking on every single system. And if you ever have to come up spontaneously with a patient education thing for nursing school or whatever, if you're put on the spot, you just say stop smoking because it's applicable to any condition. But there's an awful lot of money. America was started on tobacco. The money that allowed America to become a nation was started with tobacco. It's just been around a long time, and there is just too much money that is involved in it for it to ever go away. Sad. And it's getting pretty dang expensive too. Good question. All right, etiology here. Now this is the same etiology that we had with the neck injury. Now we're talking about low back pain. Again, same scenario here. We can be lifting at the gym and stretch out those muscles a little bit too much. A lot of lactic acid buildup, which is causing the discomfort. So what we need to do with that, what did we say we needed to do with that?
Cool down.
Move, cool down, and what? Flush. Flush.
Water.
Water.
Yes.
So you're going to need to know that. So with ligament sprains, a little bit more acute because the ligaments are attached to the vertebrae and can cause them to become malaligned. So what we need to do with them is, again, we may need to get a back brace. We want to do our muscle strengthening exercises. We want to get a back brace to help support those ligaments and the vertebrae to stay in place. We got to have those ligaments healed before we take that brace off, because the spine would become too unstable. And any kind of movement might cause a shift or the vertebrae to move or tear the spinal cord. And then, of course, this degeneration or herniation. Same etiology that you're going to have for cervical neck pain. So assessment findings, is there continuous pain there? Is the movement causing you not to twist or move or bend or that type of thing? Oh my gosh, when you have lower back pain, sometimes it's just getting up out of a chair, even though you're as straight as you can be. Just that little kind of movement is going to affect how you get up out of that chair. There can be a possible sciatic nerve involvement, and of course paresthesia, which is another word for numbness and tingling. Let me stress for just 1 minute there that movement is important for healing when you're talking about muscles. Okay. So the medical management of low back pain is positioning. So when we're talking about positioning here, let me turn this for just a minute, make sure I'm in the correct slide. So positioning, we talk about same thing with the cervical neck pain, is that you want to keep that spine in proper body alignment so that there's no stress on those muscles at all. We want a firm a firm mattress. Why? Because if you have a soft mattress, you are going to cause the back to bow greater than it naturally is. Yes, it's a fact, Jack. So you may have some medications, muscle relaxants, NSAIDs. And then if there is involvement of the disc, then you're probably going to be on steroid injections. And then heat therapy should be used intermittently. You also need stomach line. Again, this puts because you're laying flat, the spine is going to be in good position. You want to do prone push-ups as far as your exercises are concerned. A pelvic tilt, semi-sit-ups, knee to chest. We talked about proper body alignment and weight reduction. Seems like they have that too, Stephanie, in every slide.
Stop smoking. Don't drink.
There you go. All right, so when we're talking about a minimally invasive surgery, we're talking about that a minimally invasive surgery. Remember, this is where they do just one little inch, and it's a one-day surgery. You're out of there, in and out. It's not done if there's any involvement of the spinal cord. And why they prefer to do this is because there's less muscle injury when we're making an incision in the back. There's less blood loss, there's less post-op pain, and there's fewer complications. And it's usually in one-day surgery. Some people call them ambulatory surgeries. However, if we are going to do fusion of several of the vertebrae of the discs, then log rolling is going to be essential. So how many people do you need to help log roll a patient? 3.
Yeah, pretty good.
You got to have 3. You've got to have somebody that is dedicated to the neck and at least 2 people to the body so that the torso, the hips, and the shoulders move at the same time. If I personally were moving somebody that's had a lower back fusion, then what I would do is get 3 helpers and I would be at the neck. But I need somebody at the shoulders, I need somebody at the hips, and I'd want somebody at the feet. What is one thing you learned as a CNA when you're log rolling? You keep a pillow between the legs so that the hips and the legs stay in alignment. Okay, so here are some complications that you're going to have when a person is had back surgery. And the reason why these complications are pretty important is because you're dealing with the spine here. So if you have complications, you're going to start dealing with the spinal cord itself. So let's look at these. So cerebral spinal fluid leakage. Now let's talk about the cerebral spinal fluid that surrounds the CNS, the central nervous system. So you have the brain and then you have the spinal cord. And this is an enclosed system. Has anybody ever seen a lumbar puncture before? Have you seen the fluid, the cerebral spinal fluid? Crystal clear, at least it should be crystal clear. And what happens here is that you have the production of spinal fluid, and then it keeps going around and around because it's a closed system. And it bathes the tissues of the brain, and it bathes the spinal cord and keeps everybody living within that little space happy. Spinal fluid, that tissue becomes very irritable if even a blood cell is found in it. It doesn't like, this brain doesn't like external blood, loves internal blood, but hates external blood. So you get an irritation if there's blood in there, or white blood cells, anything like that. It becomes very, very irritated. So what happens when you have a fusion, you are working around the spinal cord itself, and it may require that, or not require, but it may cause some disruption of that closed system. And so you start to leak spinal fluid. And if that spinal fluid volume gets less than what is needed to bathe the brain and bathe the spinal cord, then you're going to have some problems. And the brain doesn't like it. You are also open for potential bacteria. And so what happens here is that that you start losing spinal fluid, you get a tremendous headache. The person has a really, really bad headache. And so we need to try to not get in and disrupt that fluid volume any more than it is. So we want to lay the person supine and keep them in a supine position. If you have them in a sitting position, again, gravity is going to pull that fluid, and again, the fluid's going to go the path of least resistance, and so going out of the incision near the lower back means that it's leaving the body totally. So the thing about it is that when you have a patient that's had lower back surgery, we want to keep them in the supine position until the dura heals. That fluid, remember, is helping to control the pressure in the brain. So the patient will get a headache, they'll get photophobia, they'll get nausea and vomiting. These are all signs and symptoms that you're going to see with meningitis. So this picture here, I'll come back to this little thing in just a minute, shows a lower back incision and some spinal fluid coming out. Now, one thing I want you to notice here is, look at, this is the incision, and I don't know if you can tell this at home or not, but you'll notice that this upper aspect, or the superior edge of the lateral incision here, is bulging. And that's kind of indicating that there is an accumulation of spinal fluid. Yes, sir. What?
On the picture, what are you talking about?
Right in here. Do you see that it's bulging a little bit?
Well, the mouse, it doesn't show on the...
Oh, I'm the mouse. Okay. So right in here. I don't know if you can see it. It's bulging. It's leaking here. And this is spinal fluid. And it's going to have a little bit of blood in it because you just had an incision of the dermis here, of the skin. But over here, you can see there's just a little bit of puffiness on the anterior aspect of this incision. And that's an accumulation of spinal fluid. So that's one of the things that you're assessing for when you're looking up underneath that dressing. Is there any accumulation, any edema? It looks like edema there, but it could be spinal fluid. You have to think about that. So by laying the patient flat, you minimize the amount of leakage that occurs during the healing process. All right, another, let's go back to this little chart right here. So another complication that can happen is fluid volume deficit. So again, we want to monitor the I's and O's to make sure that the patient is in balance here, you may see that when there has been a back surgery with a conventional surgery, where they've been under general anesthesia for a long period of time, there's a larger incision. I have seen zippers go down from the cervical vertebrae clear down to the sacral vertebrae. There are zippers because of the stitch scarring that is there. But what happens here is that you may see that the surgeon puts in a drain to collect blood because there has been an invasion with that incision of a large amount of tissue. So what we want to monitor for in that drain is that we don't want more than 250 milliliters in an 8-hour period during that first 24 hours of surgery, first 24 hours after surgery. Okay, so if there's a drain because of the back surgery, again, we need to notify the physician if there is more than a 250 ml output of drainage in an 8-hour period. So if the person's losing blood like that, or if there's a lot of exudate that's going, we need to recognize that there is high potential there for hypovolemia. So especially this, you got to look for, again, are you going to see this in the ACDF? No, you're not going to see this. Are you going to see this in lower back surgeries? Yes.
These complications are specific to lower back, mostly?
Well, the spinal fluid, yes.
Okay.
That you can have the cervical neck injury. That can be also an issue there as well. That didn't make sense. I contradicted myself, didn't I?
Yeah.
Sorry. Yes, it's true for low back pain. It's true for upper neck surgeries. Anywhere where the cervical column is involved. Anywhere along the back.
The spinal column.
Mm-hmm. What did I say?
Cervical.
Yeah, spinal column. I'm getting old. All right, acute urinary retention. This holds true because they have been under general anesthesia for a long period of time. So what we want to do is we want to get them a bedside commode because, again, mobility is paramount here to the healing process. So we're going to get them up as soon as possible. And we want to have the patient have a bedside commode because they are going to be weak. They're going to be in pain. And there may be some disruption of control of that urinary sphincter, or not but the bladder sphincter. So they could be having some loss of control, a little bit of incontinence there. We'd like for the men to stand, assume the normal position for urinating at the side of the bed to use a urinal. But we definitely monitor the I's and O's to make sure the patient doesn't become hypovolemic. We also want to monitor for a paralytic ileus. What is a paralytic ileus? Why are we monitoring for a paralytic ileus? General anesthesia. The person's been under general anesthesia. So the thing about it is that are you going to have bowel sounds right after surgery? Is that an expectation, a finding that the nurse should expect to find? No, there shouldn't be any bowel sounds because they've been under general anesthesia. Do we have the patient usually NPO after surgery? Why?
If you don't have any movement and you don't want to add more on top of it.
Exactly. And if we give ice too quickly, it's going to, or fluid too quickly, just water, something to drink too quickly, then it's going to shock the intestine into stopping the peristalsis. So it's going to contribute to no bowel sound. So we just got to be very, very careful afterwards not to contribute to the development of a paralytic peristalsis. You wait, you be patient. They will have an NG tube in, which will kind of help with gas distension and with nausea and vomiting if they have that need to. But we do not usually remove that NG tube until we hear bowel sounds. Okay, fat embolism syndrome. Why in the heck am I talking about fat embolism syndrome? What is it, number one? Oh, I can tell this is exciting for you. Okay, a fat embolism, believe it or not, bone has fat in it. So anytime you're messing with bone, there is the potential of these little fat, I would want to say thrombi. They're little pieces of fat. But if they start moving up into the blood circulation, there is an potential there to develop a fat embolus, which is very similar to a pulmonary embolus. It's just instead of having a blood clot, you have a piece of fat that is occluding a pulmonary artery. So if they have a sudden onset, what are the signs and symptoms of pulmonary embolus again? Shortness of breath, pain, chest pain, panicky, desatting, all the same signs and symptoms of a pulmonary embolus, only this time it's a fat embolus. And you have to recognize that orthopedically, anytime there's a disruption in the bone, there's a potential of a piece of fat getting into the bloodstream and causing an embolus that occludes an artery somewhere. All right, so one thing, a complication that can happen in back surgery is that the person comes out of the back surgery, and yes, we anticipate that the damaged nerve root up by the spine that has been compressed for a period of time is going to tingle and have some numbness associated with it during the first 24, 48 hours. However, if there is persistent pain, if there is progressive lumbar tingling and numbness, then you need to, and it's not responsive to opioids, then we need to document it and notify the physician. After an invasive long back surgery, you may very likely have this. If you have nerve involvement to begin with, the pain is caused by pressure on the nerve. So it may happen and you wake up and it may be tingly, it may be prickly, but it should go away within hours, like I said, 24 to 48 hours. And if it doesn't, then you need to notify the physician. You always are at risk for infection with any kind of surgery. So we need to monitor for infection. Now, I believe we've already had this test question before, but I bring it up to you again. If there is a low-grade fever that starts within the first 24 hours after surgery, what is it usually caused by?
It's the body response, yeah.
It's atelectasis. And it is the body's response to being under general anesthesia, laying on a bed in a certain position for a period of time, and the alveoli are not fully expanding. It is very common after surgery. And so if it happens within the 24 hours, there hasn't really been time for the surgical incision to become infected. That starts 48 hours to 7 days after surgery. But the increased temperature, the crackling in the lungs is the beginning of atelectasis because the person has not moved, repositioned, deep breathed, had a sigh, done anything. Those alveoli that were dependent for a long period of time are going to fill with fluid. So what do we do for atelectasis? We talked about that. We call it pulmonary toileting. We're very aggressive. The first hour that we notice it, we start having them do the incentive spirometer 10 times. Every hour, we turn, cough, and deep breathe. Ambulation if at all possible. Supplemental oxygen if needed, but we suction them if needed. We got to get them up. We got to get them moving. And within 4 hours, it'll correct itself. If you're aggressive with your interventions for that, but recognize within the first 24 hours, it's atelectasis. After 2 days to 7 days, it can be take up to 7 days for the infection to develop. Then the temperature will start to rise. So remember that, remember that, remember that. Okay. All right. You've already seen this beautiful picture, so you know everything about that. Okay, one symptom or a complication that's very, very rare is the cauda equina syndrome. And it's called that because this portion of the spinal column or the spinal cord, as it goes down, travels down past the pelvic area here, you have all these little tiny nerve roots that are coming across, and it looks kind of like a horse's tail. So the thing about this, it is considered a surgical emergency because it is putting, the cause of this syndrome is that it's putting a lot of pressure and swelling on the spinal nerve roots, and it causes incontinence. This is huge, people. So whenever you have a person that has had general surgery and has had back surgery, then we're looking for incontinence. And I just asked you earlier, well, what about urinary retention? Urinary retention is different than incontinence. Incontinence means you have no control whatsoever. Retention is you're going to have the kidneys making urine. The bladder sphincter itself is not working for whatever reason. For general anesthesia is basically what it is. But bladder, the urine is collecting in the bladder. But with the cauda equina syndrome, the person is totally incontinent. So it's like the sphincter's open all the time. And there can be enough pressure on the spinal column here that it can cause permanent paralysis. So anytime you see incontinence after back surgery, then there's a huge risk for paralysis afterwards. Paraplegic, have the person become a paraplegic. Okay, the best position to ease back pain is high Fowlers to allow for maximum hip flexion. Prone with a pillow under the shoulders. Doesn't even sound comfortable. Maybe some people grab their pillow and sleep. I don't know. I don't
Against
know.
your chest.
Yeah,
I don't know. I don't
Under
know.
my shoulder.
I know. It didn't sound very. Semi-Fowlers with a pillow placed under the knees. Supine with a bed flat and a firm mattress in place. Okay, but I'm just telling you this. If you see an answer choice of supine with a pillow placed under the knees, that's where you want to go, because that will relieve the tension on the lower back. The nurse should encourage a patient with low back pain to do all of the following except avoid prolonged sitting and walking. I remember that. Lie prone with the legs slightly elevated. Another comfortable position. Maintain appropriate weight and strengthen abdominal muscles. Yeah, you do.
Oh, put it your back.
It's your core.
Your core.
It's your core. What is the nurse's priority assessment for a patient after lumbar spinal surgery? Assess for abdominal distension, nausea, and vomiting. Assess for urinary retention. Observe for clear fluid on or around the dressing. And monitor for fever.
Not retention, it's incontinence. It's 3. You almost had me there, Vicky.
You agree? Yeah, it's 3.
Don't talk like that.
Okay, all of the following are symptoms of CSF leakage from the spinal surgical site except bulging at the incision site, clear drainage, possibly a large amount onto a dressing, increased pulse and decreased blood pressure, sudden headache. Is anybody writing an answer on the computer since I can't see it?
They all said 3. That's the last one.
It's 3. The 3 is the cardiovascular system. We are talking about the central nervous system. 2 different systems. All of the following are important nursing interventions for a patient following lumbar spinal surgery except teach the patient to log roll every 2 hours from side to back and vice versa. Maintain a pressure dressing to the surgical incision site. Monitor for petechiae around the neck, upper chest, and conjunctiva indicating possible fat embolism. Monitor surgical drain and report more than 250 mils in 8 hours. Monitor, no, that's wrong. Maintain pressure dressing to the surgical site. How are you going to put a pressure dressing on the back?
I was thinking of that tape that you like stretch it like.
Yeah, but are we going to put any pressure more on the spinal cord?
Yeah, why not?
It needs to? Yeah, I know, why not?
That's the only one that you're not supposed to do is put a pressure dressing on the back.
Uh-huh.
All the other ones you do?
You can do. All right, we are breaking for lunch. We will be back at 12:30. Be there, be square. And I'm not going to turn this off because I'm afraid I won't get it back. But during lunch, I will go put in your grades for the test. Any questions? Anybody on the computer? Marky Mark?
Nope, got nothing.
Okay, fine, people. I'll see you at 12:30. Shoot, I don't think I started recording. Did I start recording this thing?
Well, you never stopped recording.
Oh, good.
Just make sure you turn off your mic when recording down.
Okay, people, we're back. I have an exciting news for you. First of all, you don't have to listen to me. Jalen is here, who is an instructor with Weber, and apparently there was some mix-up. So I'm just going to turn the time over to her and let her just undo the mix-up.
Okay. Hi, guys. I'm Jalen. Hello, live people.
Yes, light.
Okay, so, can I take this off
Yes.
to talk? So, you guys have all received your schedule that was mailed to you, and you're told to register for classes. Yes?
Yes.
That was mailed to you under the impression that nothing had changed over here, but a lot has changed over here. We're in a new building. So, because we now have more simulation area, we are doing lab a little bit different. So it is correct that your med-surg class is on Thursday and your farm class is on Thursday. Nothing's different there. It is correct that you will have alternating sim and clinical either on Monday or on Tuesday. What is different is labs. So on your schedule, it probably says that labs are going to be Tuesday, Wednesday, Friday on the first 2 weeks, and they are not. Okay. So this is when labs are going to be. And can we show the peeps, show the online? Oh, just like turn it. Okay, there's going to be a picture taken and it will be put in your chat. So if you are going to sign up for Monday clinical and sim, that will be half of the class. 8 of you will be in clinical, 8 of you will be in sim, and then you just alternate every Monday. If that's what you're doing, then you are with me on sim, and lab will be the first 3 weeks of the semester, and it will be on the Tuesdays. So if you decide you want to sign up for that cohort, you'll be doing Monday sim and clinical. Then on January 12th, 19th, and 26th, you will have lab from 8 a.m. until 4:30 p.m. If you decide you want to be a Tuesday clinical / sim, that's Casey's group, and you will have lab on the first 3 Wednesdays of the semester. So the 13th, 20th, and 27th from 8 a.m. until 4:30 p.m. So everybody in this whole class will be here either Tuesday or Wednesday of each week for the first 3 weeks of the semester. On that 3rd week, on that Friday, is your skills pass off. Morning only. Will be done by noon. And then we go to clinical sim. Some of you will actually do Monday clinical on the 3rd week, and then come to lab the next day on week 3. Clear?
Makes sense to me.
It's kind of a lot to explain. Do we have a chat where people are asking questions or anything?
Okay. Yeah, it's up there.
Okay.
Hello. Thank you. Amy?
Yeah. We'll see you guys soon. Thank you, Vicki.
See?
Okay,
See, that was exciting.
if you have questions, email me, jlynbryson@weber.edu. Okay, I'll write it up here. Except for I don't have my marker. Do you have a journal?
I don't.
Can I put it in the chat or something?
Yes, you can.
If you get confused, you can always email me. Okay.
Thank you.
Thanks, you guys. Thank you.
I told you it was going to be exciting. Why? Because that means next semester, people. Next semester, you're free. Free. Okay, here we go, people. Look at us. Making it happen, making it work. Are we recording? Somebody, are we recording? Are we? We are recording. So now we have to go up again. All right. This is it.
What am I gonna do about it now?
Okay, we did that already, didn't we? Okay, here we are. All right, so we're going to talk about osteoarthritis now and rheumatoid arthritis before we go home for today. Oh, forgot. You are home today, except for these 4 stormtroopers that bared the weather today and came. Oh, I look at them with great love and admiration. Okay, so osteoarthritis today, and then tomorrow is going to be hip and knee replacement. Okay, so I'm sorry. I had soup for lunch. I know you were all dying to know.
I would. I asked you.
There we go. Okay, so osteoarthritis, it used to be called osteoarthritis, but today they changed the verbiage to degenerative joint disease. So those 2 terms are synonymous. Huh? No, not today, but in today's world, people refer to it as degenerative joint disease. And so the thing about this is that we really don't know why this affects some people more than others. We know that there is a genetic trait to it somewhere. We don't know where, but usually if it's in the family, if somebody comes up with this, that there will be a family history of it. So what does arthritis imply? Inflammation of the joint, exactly. Itis. Whenever you hear that, you're talking about inflammation. And so, basically, what we're talking about here is deterioration due to wear and tear. Now, we need to look and review our anatomy of the joint. So this is a normal joint here. We have, of course, the bone on either side of the joint, and then we have the capsule, the joint capsule. And inside this capsule, we have this synovial membrane that lines the capsule, and then we have this fluid. You guys can't see it, can you? Why? Because it's not on the right slide. This isn't working again. Oh, do I love my life? Yes, I do. Are we going to get this to work? Because you're not on the same boat as me. And it's important to be on the same boat. But it's not there. That's coming up. There we go. Okay, so let me go over this anatomy again. Here's the bone. Here's the bone. Here's the joint capsule. And then back here we have this lining, the synovial membrane here. And then there is fluid between the 2 bones. And then on the tip of each bone, there is this cartilage. All right, so there's the joint. So what has happened here is there can be some kind of injury to the synovial joint capsule. And so the fluid may leak out a little bit, causing these 2 cartilage tip bones together, come together. There's no cushion of fluid in between them. And so what happens is that when the 2 bones get closer and closer together, then these cartilages start grinding on each other. And when the arthritis pain begins to be felt or experienced by the patient, then there is this loss of cartilage here. And this is when people, somebody will ask their grandma, how's your arthritis? Well, I'm bone on bone. It just means there's no more cartilage here and there's fluid. There's very little fluid that's cushioning that, if at all. And so this usually occurs with weight-bearing joints, either in the hips or the knees. It can occur in the hands as well, especially in women, older women, but it can also occur in the vertebral column. Wouldn't that be fun of the spine? Yeah, it's where those little discs in between have just worn away. So we look at the etiology of this, what's causing this. Again, there is no definition, but we have a defined cause of that. We did say that there was a family history, or there were genetics that were included in that. But this usually occurs when people get to be over the age of 60, just normal wear and tear on the body. It's also can be caused by obesity because, again, you have this huge amount of weight that is increasing with every 10 pounds. There is an increase of maybe 7,000 pounds of pressure per square inch. So the amount of weight that is causing those two bones of the joint to come together can greatly be influenced by how heavy someone is. It can be due to a trauma, to some kind of injury. I saw a guy in church yesterday who was skateboarding. He's in his 40s. Let's picture that for just a minute. And he was talking about falling this summer, and he dislocated his ankle and broke it in 7 places. So that kind of trauma. Do you think this guy is going to have joint pain the rest of his life? I would imagine so. Occupation. This can also happen for athletes. For people, it can happen for surgeons who stand in one place with all the weight going onto the dependent bone for long hours at a time without relief. So there's many contributing factors that put people at risk for degenerative joint disease. So again, I have mentioned this in several lectures, that the wave of the future and what you're going to see as nurses in your careers is that there will be a strong emphasis on health promotion and preventative care. So what we're going to teach our patients, and you will be mentioning or educating them about when they come in for a visit, is that their BMI, their body mass index, is less than 30. Now, what is 25? Greater than 25, you're considered obese. Yes, sir. Oh, that's not you.
Also me.
I'm considered obese. I'm on like the red side.
You are not.
I'm considered morbidly obese. I am.
Well, we won't talk about myself. There are some things that I won't share. But so BMI is considered less than 30 and greater than 25 is considered obese, but over 30, then you're looking at, are you ready? Are you ready? Morbidly obese. Doesn't that make you feel good? Anyway, so they will get on medications. Now remember, a lot of people will use NSAIDs, ibuprofen, Advil, Motrin, whatever, not Motrin, Motril.
You got
because it's over the counter and it's pretty cheap, and they'll take it for years and years and years. What's that going to put them at risk for? There you go, bleeding. So that can be, where's Stephanie? Hope you came back after lunch, Stephanie. Stop or do not start smoking. Avoid or limit activities that promote stress on joints, which are high impact exercises. Does this mean that you shouldn't exercise at all? No, it just means we may need to change the kind of exercise that we want to do. Swimming is going to be low impact on the joints. We're looking again at joints. Repetitive motion is going to cause a stress on those joints, the repetitive motion over and over and over. My son-in-law works at SpaceX, and he makes one of the big old sides of the rocket that costs $500,000. So if he makes a mistake, he's made a $500,000 mistake. But he has to do his composite cutting. He has to hold a button on this handheld control, and he has developed arthritis in his thumb and his wrist because of that one repetitive motion. So it doesn't have to be like you're playing catcher at baseball where you're in a bent position all the time, or football where you have a lot of accidents. It's just repetitive motion, unrelieved stress on a joint that can cause osteoarthritis or degenerative joint disease. So you want to wear supportive shoes to prevent damage to the foot joints. I hate to give you an example about every single one of these little tips here, but it's fact, Jack. I'm old. So I've had both knees worked on for meniscus tears, but I literally am down to wearing these ugly big black leather tennis shoes because the height of the heel will vary where the pressure on my knees goes. And if I wear my good looking leather boots to work and walk around with a 2-inch heel, or if I wear a really flat, no-heeled slipper, I'll go home with my knees hurting because I put stress on different areas. So you'll find that people that have hip arthritis or arthritis of the knee may go to those super expensive old people shoe store because certain kind of supportive shoes will affect the joints. I know you were just titillated by that. All right, so we need to encourage physical therapy as well as occupational therapy. Occupational therapy would be more for degeneration of the hands. All right, so signs and symptoms. First of all, there's going to be joint pain and stiffness. So the thing about this is that the pain will intensify if you're using that joint a lot or excessively. It can be in one or more joints. This is important to recognize. Is this unilateral or is this bilateral pain that you're feeling? This is a question you're going to want to ask in your health assessment, because if usually osteoarthritis is going to be unilateral. Now, I told you that I have had 2 surgeries on my knees, but they were 10 years apart. And so I started having trouble with my right knee. I got it all fixed. I was in la la land. And then I started having trouble on my left knee. So it's unilateral when the pain is exacerbated. That is an indicator that it's osteoarthritis and not rheumatoid arthritis that we're going to be talking about in just a minute. Rheumatoid arthritis is going to be in multiple joints. It's going to be bilateral. That's not true with osteoarthritis. Osteoarthritis can be unilateral. It is more frequent in females, and you're going to want to know these. that there are bony nodes in the joints. And for hands, if you'll see the first joint, distal joint in the hands and the appendages there, the fingers, those are called Heberden's joints. Heberden nodes, sorry. Heberden's nodes. The next knuckle down, the knuckles themselves, so it's the second joint that's distal or in the middle joint of the fingers, it's called Bouchard's. Why they have them different, I don't know. But you need to know that Heberden's are the distal joint or the first joint of that finger, distally, and then Bouchard's is the middle joint of the fingers. Okay. So, what can we do for a person that has osteoarthritis? First of all, we did talk about analgesics, pain relief, because it's really hard to fix people that have osteoarthritis. They're able at first to manage the pain with analgesics and like acetaminophen or NSAIDs. It may get as bad as taking opioids, but pain is a symptom management that we're going to do. And then non-pharmacological interventions would be that the person is at rest, they position the joint so there's no stress on it, or in a comfortable position, whatever's comfortable for that joint to be in. Heat and cold, alternating heat and cold therapy, and then weight control again. So the surgical interventions for this is going to be arthroscopy, and that's where they go in laparoscopically. Oh, it's so interesting. Has anybody ever had any kind of joint repair done? Oh my gosh, this is the most interesting thing. So they do it laparoscopically, and so they'll put 3 holes in around the knee, and they look for a the one has the camera. One has fluid running through it because you got to manipulate the instruments inside the joint. So you got to have some fluid there to make that happen. Otherwise, the instrument's going to be tearing up the inside of the joint. So you're sitting there with 3-liter bags of normal saline. This is the OR nurse. And you have it hanging on an IV pole that has 2 to 4 hooks on it. And each hook has a 3-liter bag of normal saline that is fusing into a one tube that attaches to this scope instrument that goes into the knee. And the whole time during the surgery, that OR nurse is changing out those 3-liter bags of fluid very, very quickly because it's a free flow into the tube. And when one gets empty, you clamp it off and you actually start the other one before you clamp this one. And so that there is this continuous flow of fluid. And that's the biggest problem, not the biggest problem, but it is a problem afterwards, that you've got all this excess fluid that has gone into the knee during the surgery and has not flowed out. So the interstitial tissue is going to have a lot of fluid in it. And so the knee is going to be swollen, but it's not with edema. It's with this normal saline that has been just poured and chucked into this knee joint or hip joint or wherever that you're having the surgery done. But there can be a total joint arthroplasty, which is replacement of either the hips or the knees, or potentially a joint in the hand. They are doing ankle plasty, not plasties, but they're doing ankle replacements now as well. All right, now this is different. Osteoarthritis or degenerative joint disease is different than rheumatoid arthritis. Rheumatoid arthritis is a chronic progressive disease. It tends to be an autoimmune disease. We think it's an autoimmune. We don't really know, but we think that that's what it is. We know that it definitely has a genetic component to it. But it, again, autoimmune is a systemic inflammatory disease, and it affects the synovial joint. So any joint that has synovial fluid in it is going to be affected. Now, we know that there is some hormonal link to it because this is found, the majority of patients are women, but the research has shown over and over that during pregnancy, the woman will not experience any signs or symptoms, which is very problematic. I've had two friends that had children with, and the mothers, my friends, had the rheumatoid arthritis. One of them had 10 children and lived in a 2-story house. And of course, she never went upstairs. And the second one had 5 children, and she didn't have, and she had 2 stories. And so did either one of these women make the stairs? No. But the kids learned that pretty quick. And so they'd stay at the top of the stairs and taunt their mother. If they were fighting, they would continue to fight with each other. If they were spitting, they'd spit. If they'd throwing things, they're throwing things. And all the mothers could do is stand at the bottom of the stairs and yell at them. So it does have this little thing that, ooh, I'll just get pregnant and I won't feel so bad. It does have its consequences. It does come back to bite you, because both those women thought that initially. Anyway, the thing about this is different than osteoarthritis is that this can happen because it's a systemic autoimmune disease. It can happen in any joint of the body. We said with osteoarthritis, it's going to be in the weight-bearing joints of the body, although it can occur in the hands and it can occur in the vertebrae. So we just talked about all this kind of stuff. It's unclear what the etiology of rheumatoid arthritis is, other than that we've assigned it into the autoimmune disease category. This is where you have antibodies that attack healthy tissue, and it literally destroys the synovial joint capsule and other connective tissues. 75% are women, and the thing about it is that stress is an exacerbator of this. So there are flare-ups, and stress is usually a precursor to that. So the signs and symptoms that we have with rheumatoid arthritis are inflammation, just like you're having. You don't really have inflammation with osteoarthritis, except when it starts to grind. You lose that fluid and then it starts to grind each other, and that is causing the inflammation. With rheumatoid arthritis, the synovial joint fluid itself is affected and is causing inflammation, causing it to be destroyed. You are going to have morning stiffness. Now, where is the pain associated with osteoarthritis? It's with movement, excessive repetitive movement. So again, you're going to wake up stiff with that. There can be multiple joints that are affected. It will appear in the upper extremities first, in the hands. It can be moderate to severe, and it can cause deformities like we saw in the previous picture here. Did we see that? No, I guess we didn't. One more. There we go. You see, these are like a swan. They call this a swan neck here. So the thing is that it is much more severe, and it's constant. pain. So with it, the patients will often have a low-grade fever. They will be tired. And why? Excessive pain that hurts all the time causes you to become very tired. You're very weak because you can't put any stress on those joints. People may not feel like eating. Holding spoons can be very, very difficult, or forks. Person may have anemia. The ESR will be elevated. What did we decide the ESR stood for? What is it indicative of? Erythrocyte sedimentation rate. It is an indicator of inflammation. There's inflammation going on. They will have a positive rheumatoid factor, lymph node enlargement, and heart and lung synovial membrane involvement. So now you can understand that they don't feel good. It's not just their extremities that we're talking about here. So the thing about nodules in rheumatoid arthritis, remember with the Heberdens and the Bouchard's nodules, that they were related to specific joints. However, with the nodules in rheumatoid arthritis, look at them. They are occurring. They don't always occur right at the joint. They can occur underneath the joint, but they can be right on the joint as well. So it's not always, they're not always found in the joint. Okay, so the first thing we're going to have the patient do is go see a rheumatoidologist, or a rheumatologist, sorry. Rheumatoid arthritis, rheumatologist, they sound a lot alike, don't they? Rheumatologist, arthritis-ologist, whatever. Note that there is no cure. You know, I tell you about all my friends, you're going to think, oh my gosh, she's so popular. No, it's the same people over and over and over. But there is no cure for this. I've known 3 generations in one family that the women have had rheumatoid arthritis. Mother died of rheumatoid arthritis. One of the sisters is a year older than I am, is in a wheelchair. And the other one has severe affections or exacerbations with stress. So the medications that we put these people on are a little bit different. And yes, we'll give them NSAIDs for over-the-counter, but usually that is not going to help a lot because it's just too painful and it's systemic. And so, skip that. So they're going to be on steroids, which is going to be during periods of exacerbations. Again, we do not keep people on steroids all the time. It's just short term to get them through an exacerbation. They do have new medications called DMARDs, which you're going to hear about in Pharm this week. And these are disease-modifying anti-rheumatic, thank you, drugs. And you can say those 5 times.
Hey, Vicky.
Yes.
So Megan just has a question here in the chat about some examples of major organs that, in one of the previous slides, it talks about major organs that can be destroyed by rheumatoid arthritis.
Not destroyed. Remember, we're talking about the fluid here, an inflammation of that. So we talked about heart, lung, synovial membrane involvement here. So the membrane that you're not going to be destroyed. Did I say that they were going to be destroyed if I said that, which is highly likely?
It just says other connective tissues, including major organs. That's why.
Yes. And so you're looking at, but look at the synovial membrane involvement here. That is causing the inflammation. And so anything surrounding that has synovial membrane, which most membranes in the body do have to keep it to keep the organ itself cushioned. But when you have an involvement in that, it is going to be very painful around those organs, anything that has synovial fluid. Does that answer the question?
I guess so. Oh, Megan says yes. Thank you.
Okay, all right, good. All right, so back to this for just a minute. Okay, so these disease-modifying anti-rheumatic drugs, DMARDs, you're going to learn about in farms. They have made some progress on this, but remember, there is no cure. And I have to tell you, this is the most painful thing when I've watched these women as they grow older. It seems to get the effect on the body is more severe and it's more permanent. As you saw, the contractures or the deformities that have occurred in the hands, the effect is really it's systemic. So it's affecting where you may not have the deformity of the heart, you do have this inflammation around it. Which is going to be very painful. Anytime you have inflammation, you're going to have pain associated with it. And the same for ischemia. Okay, biologic response modifiers. So these type of drugs will target the parts of the immune system and signals that will lead to inflammation and joint and tissue damage. Okay. So here's what we have to do with rheumatoid arthritis. We have to educate the person to cope with it. Juvenile rheumatoid arthritis can occur at a very young age. And we have to educate the parents and the patient on how to deal with that. You're going to see that this is an multi-interdisciplinary team that you're working with, because you're not only working with your primary care physician, but you're working with a rheumatologist, and you're working with a physical therapist and occupational therapist to help protect the joints as much as possible. So you're going to see that they are not going to be athletes. They need to have adequate rest. They need proper positioning and ice and heat therapy. They need to learn to manage their fatigue and try to stay as active as possible because of the complications of immobility. Just because you are having a disease that keeps you from moving doesn't mean that you're not going to experience the complications of immobility. That didn't make a lot of sense, did it? Let me say that again, is that there's some people choose to not be mobile and therefore become deconditioned. They're not active, they're couch potatoes. But when you have a disease that keeps you from moving, you still are going to have the deconditioning of the muscles. And you're going to have the complications of a high risk for pneumonia and other diseases that can occur because of lack of mobility. Okay, so what we want to do for them is teach them low impact aerobic exercises like walking and swimming. We need to have home care management for mobility in case they need to get into a wheelchair. And we need to teach them, educate them, and help them to be as independent as possible. We're self-management is what we're looking for here when we're talking about patient education. That is our end goal, is that they can manage the disease themselves at home, that they're not having to go to the doctor as frequently as they feel discomfort. They need to get to know their bodies. They need to know what works and what doesn't work. So, what are the most common sites for osteoarthritis? Common sites: hands, hips, and knees, hands, elbows, and pelvis, knees, back, and pelvis, knees, hips, and back, head, shoulders, knees, and toes. Number one, remember weight bearing. And remember, it can occur in the hands and the back. Which characteristic of osteoarthritis is associated with Heberden's nodes? Personally, I think that you're going to see this question again. Personally, I'm just saying. So it's found at the distal interphalangeal joints. Your patient comes to the office with the following complaints, and you suspect rheumatoid arthritis. Which of these complaints would be typical? My hands are stiff, swollen, and tender. My right hand is weak. My left hand is stiff and swollen. My knees are swollen and stiff. It's a fact. Jack, 1. She is rocking it, rocking it. When a patient has rheumatoid arthritis of the temporal mandibular joint, TMJ, what is the major complaint?
4.
Yep, 4. I said TMJ because maybe people know that instead of temporal mandibular joint. Because nobody says that whole word ever. All right. In late rheumatoid arthritis, the patient may have systemic involvement called flares. How are these described? Fever and fatigue, joint contracture, morning stiffness, muscle atrophy. So the thing about it is that with rheumatoid arthritis from the very, very beginning, you are going to have morning stiffness. You're going to have some muscle atrophy because you're not moving those joints at all. There may be some deformities. But with advanced rheumatoid arthritis, you're going to have fever and fatigue. When a person with arthritis is temporarily confined to bed, the position recommended to prevent flexion of deformities is prone, semi-Fowlers, side lying with pillows supporting the shoulders and legs, and supine with pillows under the knees.
You might have mentioned something about 4 earlier today. You can go with 4.
I'm going to read to you the answer because this is an unlikely answer. Prone. It's actually prone. What we're saying is that you're in pain. The position is that doesn't cause any greater difficulty and pain. So you risk contractures, your risk for flexion and contractures. If you had arthritis in your hips or knees, which position would help you not develop contractures? Remember, this is not a back problem. This is a joint problem. You have to have your hips flat against the mattress and your knees flat against the mattress to not cause any more pain. I thought that was very interesting. I personally myself did not choose that answer, but I gave you the rationale for it. Okay, because arthritis is not curable, many cures are marketed to patients with this disease. What should the nurse encourage the patient to do? Buy special ointments and creams or tonics. Check with the Arthritis Foundation for appropriate treatment modalities. Take advantage of clinical trials or experimental therapy. Take herbs and vitamins. 2. Dos. In rheumatoid arthritis, the autoimmune reaction primarily occurs in the joint tendons, ligaments, synovial tissue, interstitial space. 3. Pathophysiologic changes seen with osteoarthritis include joint cartilage degeneration. Thank you. Megan said all of them, so we're going with that because it goes faster. In what way does obesity influence the development of osteoarthritis? Obesity has no positive or negative influence. The high body fat levels of obese patients lubricate the joints. The obese person has reduced inflammatory response, and the extra weight of obesity increases the degeneration rate of hip and knee joints. There you go. All right, so I got this little picture here of an arthroscopy here. And again, we talked about shooting in laparoscopically these 3 instruments. There should be one more. Did I ever tell you I got one of my needle sticks from a surgeon? His name, this was a guy in Oklahoma, so you'll never go to him, so I don't worry about it. But his name was Dr. Jabor. And I called him the Dr. Jabber because he talked all the time in surgery, incessantly, nonstop. I don't know if he didn't have anybody to talk to at home, but he just would talk. But the problem with him as a surgeon is he talked with his hands. So I'm sitting down there after this is all over, and I've got the knee in place because he's suturing these incisions shut. And he looks up to tell the circulating nurse, and he comes down with that little suture needle and just goes through my finger. Did I love him? All right, so this is the inside of the knee joint, and this is torn cartilage. And look at this flap here. So when you have a cartilage tear like this, what they'll do is they'll go in and they'll cut and scrape and make this nice and smooth again. Now, the problem is that you've lost a significant portion of the cartilage there, but at least the immediate pain is relieved. Because why? Because this is flapping around all over the place and affects a lot of nerves, and it hurts. Yes, it does. Oh, and this is joint replacement. Don't worry, Madison. Where are you? Maddie, are you there, Maddie? Where are you? Do you go by Maddie? Do you go by Madison? We've only got 3 or 4 of them between PN1s and PN2s. I don't know if she's there. Anyway, she's doing hip replacement tomorrow, discharge teaching. But this, has anybody ever seen a hip replacement? Oh my gosh, it's the most brutal thing.
Cool.
Secondary to cesarean section is probably the most surprising surgery I ever watched, because they take, I swear if they had a sledgehammer, they'd use a sledgehammer, but they're pounding this portion. Can you guys see this at home? You don't even see it there, do you? They can't see it on the video. Okay, so they're pounding this portion into the femur, which is a large bone. So for them to pound this in there, this whole thing in there, they are pounding. I mean, just with full force and not 1 or 2 taps. It is just until they get it into the position that they need. Because if they don't get it down far enough, or if they get it too far down, then the socket, which is placed up here, is not going to meet with the ball. And so you're going to have a constant dislocation of the hip because it's not going to stay in the socket. So it's got to be perfectly into the right depth, but to get it to that depth, you're going halfway down the femur, for Pete's sake. And you can understand why infection is such a high risk for people with hip surgeries and knee replacements, because they're just so massive. So we're going to talk about that tomorrow. Oh, look at what time it is, people. It's 1:20. Oh my gosh. Oh, let me give you one more slide. I know. All right. So the biggest, oh no, I think you're going to talk about this tomorrow. We'll wait. If she doesn't talk about this tomorrow, then we'll talk about it tomorrow. Okay, goodbye. You all are dead to me. Thank you. Any questions? Any questions from the dead? No? All right. Well, remember, quiz tomorrow morning, 8:15. Be there. 8 o'clock. Be there. Be square. And learning activity tomorrow evening, due at 11:59. Goodbye. Actually, I'm sending you love and vibes of good knowledge. All right. See you. Bye.